I'm going to introduce our second speaker, Dr. Thomas Marin from New York, and I made the mistake this morning by asking if he was a basic researcher. He's not. He's a medical oncologist that does lung cancer in phase 1. And he's going to talk to us about neoadjuvant mRNA.
All right, today we're going to talk a little bit about the role of targeting neoantigens in the neoadjuvant space. There's not a lot of data here. We haven't seen any of these mRNA approaches in the preoperative space because these constructs take a long time to make, but this technology is obviously improving very quickly, and thanks to COVID, Moderna and BioNTech have a lot of money to play with, so I think we're going to see some exciting developments. These are my disclosures, same from yesterday, but all the bolded companies are ones where I've worked with them, and I'm going to show you just some of the plans that they have. So neoadjuvant neoantigens is a big title. We'll start with neoantigens and how to target these. Obviously, the reason why we've seen all this success in the neoadjuvant space is because we're revving up T cells that are recognizing neoantigens. And here's the obligatory intro to anything talking about neoantigens is when we are killing cancer cells with chemotherapy or radiation, or cancer cells are really growing in an aberrant fashion and constantly just lysing and releasing their contents. It's really those mutated proteins that can be taken up by antigen-presenting cells like dendritic cells, and they are the ones that prime T cells. And it's these prime T cells that are really responsible for the responses that we're seeing to things like PD-1 blockade. And there's a variety of different types of neoantigens that are possible, really based on all the different types of mutations that we see within tumor cells. So these can be single point mutations, indels, all sorts of different rearrangements, all of which are technically foreign proteins and should be recognized by your immune system. And we can study these by getting biopsies of tumor. Oftentimes we want to biopsy or take lots of different samples to really account for tumor heterogeneity and intratumoral heterogeneity of neoantigens. We then have to sequence the germline DNA. Usually we'll just use that with PBMCs, so take a tube of blood. We can identify these mutations by doing transcriptomic data, so looking at the RNA in the tumor, we can actually confirm what we think will be, in fact, translated into mutant proteins, and then we can use a variety of different in silico algorithms to sort of predict which are going to be the most immunogenic of these mutated proteins, and we use those to make vaccines. And the last 2 decades, we've seen we've been doing vaccine approaches for more than 2 decades, but we've seen a lot of improvements in the last 2 decades. One thing that we've really focused on are in situ vaccines. So, a lot of the times we think that we're smarter than we are with these in silico algorithms to predict what's going to be most immunogenic. In situ vaccines are a lot easier to do because we're really just allowing the immune system to do the selection for us. And so we have a lot of different in situ approaches where we inject tumors directly with some sort of adjuvant. Oftentimes we'll give a little bit of radiation to release some antigens as well. And so you're basically allowing the body to create a vaccine in the site of the tumor you're vaccinating. And then the goal here is to sort of try to elicit abscopal responses. We have this vaccine that we're going to be presenting later this year. There's a variety of different peptide approaches that have been pursued in the last 2 decades. These are somewhat promising. They really are limited by the ability to make a lot of the neoantigens ex vivo and actually solubilize them and administer them to patients, but they've been tried in lung cancer and many different tumor types with modest success. And then most importantly, and I think most excitingly, are the nucleotide approaches. And so there's a variety of companies looking at RNA and DNA approaches to actually get your body to make the neoantigens in vivo. So there's lots of different examples of personalized neoantigen vaccines in lung cancer using peptides. This is one study where while patients were getting induction chemoimmunotherapy in the metastatic setting, they were making the peptide vaccine. It does take a few months oftentimes to make these peptides, at least with the current technology. And then they were administered the adjuvant, or it's not really adjuvant, in the consolidative setting, I guess, it's metastatic, but they continued getting pembrolizumab, and then they dropped the chemotherapy maintenance and they gave them the neoantigens. And it was a nice study. This is a beautiful paper showing the immunogenicity. If you look at the responses, though, it's actually less than we would have expected from Keynote 189. And so it's not the most impressive data. And this was an approach by Neon, which was brought by BioNTech, and they actually have basically shelved peptide approaches in BioNTech, 'cause they obviously have a different technology. And I think one of the biggest issues with peptides, like I mentioned, is the logistics. And so there was 38 patients that were actually enrolled in this trial, but only 16 were actually completely vaccinated. So a minority of patients actually made it through the whole trial just because of the logistical issues. So there's multiple different nucleotide platforms. I've been involved with the DNA approaches that are being led by Genios. And so here they actually make, we sequence patients. This was in HCC actually, so we sequenced patients while they were on first-line TKI, which is no longer a standard of care. But at the time it was. And so we would biopsy them, and then we would sequence them. We would identify up to 40 neoantigens, and we would put this into a plasmid, and we would actually electroporate patients, which sounds like torture. You actually just sort of put this plasmid right under the skin, and you use this little gun thing. They call it a gun, which also makes it sound scary. It actually is not too scary, and you introduce those plasmids just into the tissue in your arm, which then make the vaccine peptides, and they also encode for IL-12, and so that really sets off the immune system. And here we actually demonstrated a doubling of the response to checkpoint blockade in the second-line setting. So again, modest success. We need larger studies to show benefit. And then both Moderna and BioNTech are looking at a variety of RNA approaches to encode neoantigens. I'm sure many of you saw this study from Vinod at MSK that was run through the IMCOR consortium with Genentech Roche. They collaborated with BioNTech, and they took these pancreatic patients that were having their tumors resected. They made personalized vaccines, and about half the patients actually had a immunogenic response. And even though you're given FOLFIRINOX to these patients, which you think would knock out any sort of immune response, it did persist, and the half of the patients who had immunogenic responses actually are doing quite well. So it's a pretty tantalizing bit of data, particularly in a setting where we usually don't see any response to any sort of immunotherapy. And finally, I think Moderna is really the farthest along in making these vaccines across tumors and also in lung cancer. The V940 construct, which is sort of a collaboration between Merck and Moderna, uses the same sort of technology approach. They basically make an RNA that encodes up to 34 different neoantigens. In this study, patients were randomized to get adjuvant pembrolizumab or adjuvant pembrolizumab with the V940 vaccine. And so these are in patients with high-risk melanoma that's been resected. And here, this data continues to mature and get more and more impressive. We really are seeing a significant improvement in event-free survival or recurrence-free survival. So I think this really this is nice proof of principle that we can vaccinate patients against these neoantigens, and we will improve responses, at least in immunogenic tumors. Obviously, the holy grail is things like colon cancer and pancreatic cancer. So this is also being done in lung in the adjuvant setting right now. So this is a study that is currently enrolling, and they have another one that's going to come out that's similar to this. But here, patients are getting randomized to either pembrolizumab or a combination of pembrolizumab with V940 after they have surgery and adjuvant chemotherapy. So this will be a nice first proof of principle in lung cancer. Now, as far as moving these neoantigen approaches into the neoadjuvant setting, obviously neoadjuvant, we believe, based on all the data that has been shown here, is better than adjuvant. Some people would argue adjuvant is the best place to use immune therapy because there's a lot of data demonstrating an inverse relationship between tumor burden and response rate to checkpoint blockade. So in the adjuvant setting, you're dealing only with micrometastatic disease, so arguably that is the best place to give immune therapy, and that's one of the arguments for why the adjuvant setting is particularly exciting for these vaccines. I'm not going to go through all the rationale for neoadjuvant because we talked about it all day yesterday. I'd say the bottom one that is particularly unique is that surgery is inherently immunosuppressive. Sorry, surgeons. It does sort of disrupt normal immunity, and so ideally we would try some sort of vaccinal approach early on. That's one of the reasons why we think that giving immunotherapy in the neoadjuvant setting is also beneficial, is you really are kind of vaccinating patients against their own neoantigens while the tumor is still there. And so the proof of this vaccinal effect really came from probably the first study in melanoma, which was randomizing patients to adjuvant or neoadjuvant immunotherapy. And this was the first time, not only did the neoadjuvant patients do slightly better, obviously extremely small cohort, but you did see induction of de novo T cell clones and expansion of tumor-specific T cells. And so we really had the first benefit that we can kind of vaccinate patients by giving neoadjuvant immunotherapy. Obviously, melanoma, once again, is leading the field here. In the neoadjuvant space, they demonstrated when you compared neoadjuvant followed by adjuvant pembrolizumab, so perioperative pembro versus just adjuvant alone, huge improvement in recurrence-free survival, which is what we would have predicted. I'm not sure we'll ever really be able to run this sort of trial or complete this sort of trial in lung cancer, although it would be nice to have that data. And when you look at all the data that we looked at yesterday, I would say, once again, the perioperative approach is really superior to the adjuvant approach, especially when you think about the adjuvant. You're already taking out, 20% of the patients or more that would not have been in the curves on the left side. So I do think that the perioperative approach is better. And it's really important, and particularly now that hopefully we're giving most of our patients neoadjuvant chemoimmunotherapy, 80+% of these patients are not achieving a path CR. So these are the patients that we're worried that there might still be residual micrometastatic disease, that there's still disease within the tumor bed. So we really need to find some sort of intensification. That we talked a lot about intensification approaches, and I don't think that just throwing another year of pembrolizumab is necessarily going to be the fix. I think that we need to look at different fixes. So just last slide, I would say there's a few different ways in which we might be able to use these neoantigen vaccines as we continue to develop them in the adjuvant setting, and as this technology rapidly improves. Hopefully we'll be able to make these vaccines within 3 to 4 weeks if we get some tissue. So one approach is that with neoadjuvant chemoimmunotherapy, we might be able to administer a neoantigen vaccine. And then if patients have a path CR, we can just watch them. If they don't, then we really do need some sort of intensification, because we really gave the kitchen sink to these patients. But I think that this kitchen sink approach, you might be able to get the highest path CR rate. So we might have the highest cure rate by really giving everything and activating the immune system in the preoperative setting. Conversely, the Patrick and the LCMC3 and many groups have looked at just using neoadjuvant immunotherapy alone. We could give neoadjuvant immunotherapy with a neoantigen vaccine and really find a way to take chemo out of the regimen, because a lot of people, I don't like giving chemo. A lot of people don't want to receive chemo. So it'd be nice to get rid of that. There, once again, if you have a path CR, we could probably just observe these patients. If you didn't, at that point, we might be able to give some adjuvant chemotherapy with or without immunotherapy. Arguably, this is the most attractive immunologically, because we're vaccinating these patients in a very immunocompetent state. We're not giving them chemo and steroids. But not giving chemo can be a good thing, but it also could be a little bit concerning in patients that aren't going to respond. And finally, the approach that we're looking at with at least the Merck's trial is looking in the adjuvant setting. But here we could give neoadjuvant chemoimmunotherapy, and specifically in the patients that don't have the path CR. I think that's the patient population where you really want to induce de novo immunity, because those T cells have been taught to recognize some of the cancer cells. They've maybe killed 90% of your tumor. That remaining 10% must have some sort of neoantigens that haven't been really instructed to your immune system. And here, you have adequate time to produce the vaccine in the adjuvant setting, and it's attractive also because we were just talking about this, if you are sequencing the tumor that has been edited, basically, you're identifying the most important neoantigens as opposed to vaccinating them against a neoantigen that they're already responsive to. So obviously, thanks to all the patients that make all this beautiful data possible. Happy to take questions.
So what a fast-moving world, and who would have thought something good would have come out of COVID? You showed us the melanoma adjuvant trial, which made the New England Journal, which made all the melanoma doctors go crazy. And that's led to a phase 3 melanoma trial, but it's also led to phase 3 lung, colon, breast, and bladder. And so I guess my question to you is, do you think you can take that melanoma trial and move it to all other tumor types?
I think, unfortunately, our melanoma colleagues are lucky in that they have such high response rates. I think that, when you look at the delta between their controls and whatever their novel combination is, that delta always shrinks when we move from melanoma to lung cancer. That's why, it'll be interesting to see if we eke out any benefit with LAG3, because it's a pretty minimal, benefit in melanoma. And I think that it probably shrinks even more when you move to other tumor types that are less immunogenic, like colon cancer. Although this might just be the thing that we need for other tumor types like colon cancer, where, PD-1 alone hasn't worked, but maybe it's just because we haven't had adequate vaccinal effect, adequate priming of anti-tumor T cells. So I think, we just have to do the trials and wait and see. And like you said, thankfully, they have a lot of funds to sort of try it and everything. So we can hopefully learn a lot from those trials.
We were talking earlier, and I asked Merck how the vaccine is actually made. And that's Moderna, and nobody knows, and it's private.
Well, I think that, with these neoantigen vaccines, the proprietary part is really the antigen calling. And so we at Sinai, we have our own in silico algorithm. Everybody, we publish ours, it's not private. But, Moderna and BioNTech each have their own algorithm to predict both MHC class 1 and class 2 alleles. And, I don't think that any of them is probably perfect, but they're all very secretive about it for sure.
Okay, we will look forward to your vaccine.
Yes.
I have a question. Oh,
Yep.
Can I ask one more? So I had a question. I'm curious to know if there have been any increased signals for toxicity when combining sort of vaccination strategies with immunotherapy in terms of immune-related adverse events.
So we haven't seen any so far in our studies, and they haven't really seemed to be any, in the Merck Moderna studies. You obviously have some sort of, a robust sort of antiviral response. You're injecting people with antigens, and so patients can have fevers and things like that. One thing that we are always cautious of with our algorithm, and I'm sure Moderna and BioNTech do this also, is you don't want to vaccinate somebody with a neoantigen that looks very similar to a normal antigen, not only because to the unmutated antigen, not only because you are probably going to have tolerogenic effects, so it won't be very antigenic, but you could also end up inducing autoimmunity, sort of, de novo IRAE that you wouldn't have before. So.
Interesting. Okay.
Thank you.
Thank you.